Hello, I'm Dr. Jeff Verzella. I'm the program director at the UPMC Williamsport Family Medicine Residency. And today I'm going to demonstrate the delivery of a breech baby using our model. Important to know, this is part of what you would be taught if you do the ALSO course, the Advanced Life Support and Obstetrics course. But it's nice to always have a video to be able to look at because this happens so rarely. It's basically going to be an emergency type of situation. Before we start, I would like to review a mnemonic that we always kind of go through. You'll learn this in the ALSO course, but we also try to review this in our head if we know a breech delivery is imminent. And the mnemonic is careful, and the C stands for checking for full dilatation, checking for fetal presentation, which we know will be breech, checking for a cord prolapse before we start the delivery. The A would stand for await the delivery of the umbilicus down to the introitus, maintaining the sacrum anterior so the back will be towards the ceiling. R is for rotating the arms. E is for entering the vagina for a maneuver called the Mariso-Smelly-Veet maneuver, or MSV, which will help deliver the fetal head. F is for delivering the fetal head. U is for continuing to keep the sacrum or the back up towards the ceiling. And then L is lifting the baby up and then usually onto mom's chest or mom into mom's arms. It's going to be a team approach to actually deliver this baby in total. But to start with, I wanted to run through the mnemonic. Now, the other thing that I want to show you before I actually do the delivery is this MSV, Mariso-Smelly-Veet maneuver, because this is how we deliver the head. The head is the last part to be delivered after the butt comes through and the torso comes through. And the head has to be delivered in the right flexion attempt to be able to deliver through the vagina. The maneuver that we do involves helping flexion, where we take our dominant hand, so for me it would be my right hand. I take my index finger and ring finger and put them on the shoulders of the baby, with my middle finger going on the occiput. My other hand will come, and the first two fingers will come on the maxilla. The old way of doing it, the original way that they developed, was to put a finger in the mouth to try to help flexion of the head, but this can dislocate the jaw. So we always want two fingers on the maxilla. This will be the position to help deliver the head when mom starts to push in this last phase. This will also be accompanied by someone wrapping a towel around the body to help support the trunk and elevate, and also another person giving suprapubic pressure to help flex the head. We want the head to be flexed in delivery. So this maneuver will be important, and I wanted to show you it before we got into the vagina because it's hard to see. All right, so we're now going to do the delivery of the breech. When the baby comes in, the butt will be the presenting part. You'll obviously check it with digital exam and make sure that she's completely dilated, which is sometimes difficult when you don't have a hard surface of a skull to make the differentiation between what's cervix and what's baby. But assuming that this baby is truly breech, the butt will begin to distend the perineum just as a vertex delivery would. And as the baby starts to come down, you'll notice that the hips will be in an AP presentation, so a vertical presentation. That's the only way that they can really fit into the subpubic area and vaginal introitus. So baby's back will either be to the left or to the right, depending on which side is being faced. In this particular case, we have baby facing mom's left. So you'll see as the buttocks start to come through, and we just let the buttocks come through until the hips get delivered. Nothing for us to really do at this point. I'm going to now have help in delivering this baby. What will happen is once the buttocks and the hips are delivered, the baby will either rotate itself, or we assist in getting the sacrum up. This is key. We want that sacrum pointed towards the ceiling to be able to do the rest of these maneuvers. So all of the rest of this will be with baby sacrum or back up towards the ceiling. At this point, we don't want to put our hands on there at all. So you can keep your hands down, or you can use them just for perineal support and to help guide the buttocks, but no pulling, no assisting of the delivery, and mom starts pushing. So mom is pushing, baby's coming, our hands are either off or just resting on the perineum and the baby buttock until we get to the umbilicus. So the next stage of this is the umbilicus. So the we're going to assume we're watching baby's umbilicus is now delivered at the perineum. This is unfortunate. What we do is we reach up and we pull down about 6 inches of umbilical cord. We pull that down in order to give a little bit of slack so we don't rip the cord when we're delivering the rest of the trunk. And you can also palpate for pulses in case we didn't have fetal monitoring on to make sure that the baby is still viable and doing well. Once the umbilicus is delivered and we pull down some cord, we now have the ability to help. Our thumbs go over the SI joints and our fingers wrap around front to the front of the pelvis. And now while mom is pushing, we can give a little bit of assistance. Like this. We can then deliver the legs if we want to reach up with 2 fingers, go posteriorly, grab the thigh, wrap around the thigh, and deliver the leg out this way. Or if we want to wait, the legs will pop out simultaneously. So I'll let this one pop out. So we continue to deliver, and we can rotate, and we can actually help with a little bit as mom is pushing, rotating back and forth to help until we get down to the shoulder blades. At the shoulder blades, we stop because this is where we want to deliver the arms. The way to deliver the arms is we rotate the baby obliquely, and usually the arms will still be flexed up inside. So we rotate obliquely, we reach up under the pubic symphysis, we grab the upper humerus, and then we grab the forearm. We try to flex the forearm against the humerus and then sweep it across the body and out. So baby's forearm is out, baby's upper arm is out. We then rotate to the other side. Make sure the arm is not yet delivered. There we go. We rotate to the other side. We're still holding baby. We reach in, we pin the forearm against the humerus, flex it, and then sweep it down the side of the body. Now both arms are delivered, and what we do is we let the baby restitute back towards facing down, back up towards the ceiling for the last part, and this is where we deliver the head. So we take a little bit of a breath here. We have our team come in, wrap the baby in a towel. You can actually hold the feet if you want with that hand. And our other assistant will begin to present suprapubic pressure to help flex the head. And I will put my fingers in for the MSV maneuver using my right hand. You have that. 2 on the shoulders, and then my middle finger on the back of the skull. My other hand will go in underneath. 2 fingers on the maxilla, 1 on each side. And now as a team, we tell mom to start pushing. We'll give suprapubic pressure at the same time. And as I'm delivering the head with downward force, my assistant will pull up on the towel. So ready, mom? Go ahead and start pushing. Baby's head gets delivered, and it can go right onto mom's lap. So that is how we deliver a breech baby in an emergency situation. Again, we don't really do planned breeches anymore, but if a mom comes in, breech, ready to deliver 10 centimeters, you have to be prepared. Your whole team will need to get ready, nursing, calling your obstetrical help in if needed to, and make sure you have a team effort to do this.